Good morning, Les. How are you?
I'm fine. You?
Pretty good. How goes the show?
Well, it's moving.
Yeah.
This, the schools have taken a bit of a roller coaster, trying really, really hard to open up, and then they've had to switch gears. It's made it hard. Although the numbers, if you're following the numbers, it's pretty obvious where we need to go. I've really encouraged schools to, when they talk to their communities, to explain the numbers and then explain that it's the community's actions that will make the difference. And we want kids to be in school. That's our goal. We will do the best we can with them, looking for better ways to communicate and involve kids and all that. And it's going to be better than last spring, but it's still great to have the kids in school. And parents are just upset, in their community. Maybe there's 5 or 6 people that have COVID or something, and they're like, that's not very many. So why can't the rest of us be in school? And those are hard for school districts to just say, this is the way it's. The problem is that there are communities that open schools and their COVID rates hit the roof. So we're trying to be really careful and make sure we have the capacity to deal with them. And I don't think that we have it in our communities very well. We aren't. I mean, you guys are a little better in Tri-Cities where you can just go get a COVID test, but most places you have to show reason and a significant reason. And the tests are. There's still a limited supply of tests, and the response rates. Well, they're down, I guess, to 48 hours, where they were up to 2 weeks for a while. And if I open a school and I have a positive kid that I don't know for 2 weeks, I mean, it makes the isolation quarantine stuff kind of useless. So as we get better with our community testing and all that, I think that we're going to be safer open schools. And I hate saying that because I think there's a lot of benefit to kids being in school. And I think instead of bellyaching about the problems, I think we need to figure out how to overcome them. I'm sorry, that sounds like but I have so many people, well, what all these kids that are lonely? And I have the kids that just, they're really depressed because they're not around their friends. And well, let's find other ways to do this then. Let's pay attention to this and make some other things, because part of growing up, and this is not trying to be cruel, is learning how not to be around all these people and still be okay. So figure out how to do that. Build that as a strength instead of as a detriment. We build our individual abilities, and then have a way to communicate with people when you are needing to communicate. I've suggested that maybe the smaller schools, make a calendar and just make sure every student gets an eye-to-eye contact maybe once a month or every 2 weeks or something. That means teachers will drive around and we'll wave, and just make sure every student knows that somebody is looking for them continually. Personally, not because of the classes, not because of your assignments, not just we're going to look for you. It's going to make a difference. So, but we'll see how it all turns out. I know I just yak along, don't I? Anyway.
Oh, I love it. I think that those are great words of resilience, really. I mean, that's part of evolution, is we have to be resilient as a society to be able to overcome. And with regard to the people questioning, well, why is it the Boys and Girls Club can open up, right, but we can't open up the schools? That question comes up every week at the local decision makers meeting that the Benton Health District has. And Amy Person, Dr. Person, is just very and says, Mayor-elect, it's the numbers, it's the quantity of people that are coming into the school system. You're talking about 600, not 16. It's the sheer volume of exposure. It's just the magnitude of the problem when you get all of these kids interacting together. So, you know, I think you just have to keep beating the drum. And I love some of those things that you said about let's figure out a different way of doing business. That's what everybody's having to do right now. And as a result, I think we'll have some really good learnings out of it, and that we can carry forward.
I think we need to recognize that there are side effects or adverse effects or whatever we want to do. But instead of saying we have to be together in school is the answer, we need to look for others. And because we know that being in school is dangerous in other ways, let's find other ways to socialize our youth. Mm-hmm. And by the way, we complained and complained and complained about all these kids that did all their socializing on media, on social media. And now, you know, I mean, I don't know. It's just, somehow we're going to have to come around to figure out how to make it all work.
You're in an interesting position at this time. You and Patrick being in the academia world, and I know my daughter works for California College of the Arts, and they're having to revamp their curriculum. So.
Right, Eastern is almost, let me put it this way, 90 to 95% online for fall, and will most likely be that way in the winter quarter. So that decision was made 2-3 months ago. So we kind of jumped the gun in the eyes of some, but I think that has been vindicated by the unfortunate rise in cases throughout Eastern Washington.
Well, Patrick, the staff talked yesterday about whether or not to use webcams. I would throw it out to the board as to what you guys want to do. If you would want to keep our webcams on so we can kind of keep track of people, or if you would like for us to turn them off. Sometimes it slows down the system. Sometimes people freeze up. What are your recommendations as our fearless facilitator?
You know, I'm kind of of two minds on this. I like to see people when we talk, but it can be a bit distracting, especially as we get a few more people on. Perhaps a solution would be once we get to the conversations and the feedback from the board to each of the presentations, and then at the end I think Chelsea can do this from her perch. We click on our video or our webcam to the green, but you know, I'm up to whatever people want, but that would be my suggestion.
But say President Gibbons.
It doesn't make any difference to me now that I've got my webcam so that it works. I mean, I wore a suit.
Yeah, well, we don't know what's on the bottom of that suit, Brian.
The rest of the suit, because I had another board meeting after this one. Yeah. It doesn't make any difference. I think that as long as we can see what's coming up on the screen, it's fine. So
Chelsea,
if the bandwidth is freezing up people's screens, we should just cut the webcams off.
yeah, and that may be the case. I just got my bandwidth expanded here on Monday, so I think I'm fine, but other people may not be in that situation.
All right.
Chelsea, could you do that? Could you go toggle back and forth between webcam on, webcam off globally for all the people in the meeting?
So are you asking if I can turn on everyone's webcams, or?
Yeah, so I think at least in some of the meetings I've been in, there's a sort of as the host or hostess, there's a master switch that you can turn off and on. Is that true or not?
I'm not familiar with it on here. I think everyone has to turn on their own. I could go through and turn them all on manually. I don't see a master switch to turn them all on, though. I think people have to allow that.
Well, if we did this, we turn them off at a certain point, then you could, when we get to the conversation part of each presentation, and then at the end, could you turn them on again? Could you do that?
I believe so. I think so.
Okay, good. Why don't we try that? So how are we? We've got 5 board members, 1, 2, 3, 4, 5. Anybody else? I see Madeline's the one on the right-hand screen, the furthest right. So you may have been the last one to join here, Madeline. I don't know. Is there anybody else from the board? I see Kat, I see Laurel, I see Brian, and of course Les. Is that it so far?
Hi, Patrick. This is Sandra. I'm here just without camera.
Oh, okay, great. Hi, Sandra. So we got 6, and I think, Carol, you said that we're going to have 11 altogether.
Yes, and so if you wanted to, Brian, we could have Chelsea go through the list of who's on the go-to right now so we would know who all's here.
I think that would be good.
Okay.
All right, I will start at the top of the list. So Becky Cohn.
Good morning, everybody. Becky's here.
Hi, Vicki.
I have myself, Chelsea. Hello. Diane.
Good morning, everybody.
Good morning.
It looks like I have someone logged in as Greater Columbia ACH. I'm not sure who that would be.
I think that's me. This is Lauren. Sorry.
Oh, Lauren. Okay. Hello, Lauren. Sam?
She's here. She's on mute.
Good morning.
There she is. Okay. I see Wes.
Good morning. This is Wes Lucky.
We have Brian.
Here.
We have Brittany.
Good morning. I don't have video, but I'm here.
All right.
We have Carol with us.
Morning.
Eric. Eric, you're on mute, but I think I saw you say morning. We have Kat.
Morning, everybody.
Good morning.
We have Laurel.
Hi, good morning.
We have Les.
Good morning.
We have Martine.
Good morning. I'm here.
Looks like we have Megan DeBolt with us. Looks like we have our fearless facilitator, Patrick, with us. People for People, Madeline. Looks like we have Ruben with us.
Good morning.
Good morning.
And okay,
Is that it? Is that it, Chelsea?
that's all I see. And if any more join us, I will see anybody else. But that's all I see as of now. So we have 1, 2, 3, 4, 5, 6, 7 board members with us today. That's not a quorum, but hopefully more will join.
I think, and Carol thought that we would, Brian, we would get up to a quorum later on in the meeting.
Yes, we're expecting Commissioner Ron Anderson and Dan Ferguson to be joining us.
Okay.
Okay.
I think we should start anyway.
Yeah, shall we get started? Is that okay, Brian?
Yes, please.
So again, what we'd like to do today is to review where we've been and to look forward to where we might go. And so we had a retreat about a year ago this time. We had some tentative steps in terms of planning where we might go, and those are going to be reviewed here shortly. But why don't we go to the next slide, Chelsea? And just point out that really what we want to do today are just 2 things, simply, besides have a really good set of conversations. The staff is going to help us review what we're going to call core competencies of the ACH, as well as put in front of you, board members, the future opportunities that they see for the ACH that might come into play, perhaps not in the next year or 2, but certainly thereafter. And then by the end of our meeting, we'd like to get your sense whether you're comfortable with the staff going ahead to develop a plan for 2021 and beyond that we think could be done in the next few months, hopefully presented sometime in early 2021. So that's really what the simple agenda is for today. Does anybody have any other thoughts that they'd like to bring up for our retreat?
I think that's great.
Okay. Well, then let's go to the next slide and just give you an overview of how this will pan out specifically. You're going to hear from Carol shortly, just in a minute or so, under the first entry there, future states and recommendations. And then we'll start the review of the staff's assessment of core competencies. There are 3 of these, and you'll hear from 6 staff members on each for the total of those 3. In between, we'll take a break. After the break, we'll continue with the competencies discussion, and then we'll hear from both Lauren and Becky under marketing analysis and funds flow. And we've allotted quite a bit of time, I hope it's enough, at the end of the meeting just for a general discussion of what you've heard. After each of these core competencies, you will have an opportunity to weigh in for about 5 or 8 minutes, just to keep the conversation going. So that's what we've planned. I hope that meets your approval. I've gone through this a few times with the staff, and I'm very impressed, and I hope you will be impressed too with what you hear from staff, what you see from staff. A bit of housekeeping then, so please, like all these meetings, just keep your audio on mute. Chelsea, can you go through now and take the webcams off? Or should we do that individually?
I think I did it, but I'm not sure. Is everyone still seeing webcams on their screen?
Yeah.
Oh, okay. Here, wait. I think, what about now? I'm doing it one by one.
Yeah, you're doing it.
There we go. Okay. Are we clear?
Yeah, we're there. Very good.
Awesome.
Okay, so I'm going to turn the floor over to, if I'm the fearless facilitator, I'll turn the floor over to the fearless leader of Greater Columbia ACH, and you know who that is. So Carol, take it away.
Great. Thank you, Patrick. And thank you to those board members that are joining us today. The staff has long awaited the board retreat. We are so sorry that we couldn't be doing this in a lovely setting such as we had chosen in Walla Walla at a possible winery, but you can envision yourselves maybe, now that we can't see each other on webcam, you can envision yourselves in a lush setting, maybe looking out the window at rows of grapes ready to be ripened for the harvest. So we thought it would be really instructive to first of all start with, you can go to the next slide please, Chelsea, with what happened last April. You might remember that, I think it was even Eric that had suggested that scene from Apollo when Tom Hanks looks out the window and he remarks, the world's getting awfully big in the window. And this is during that time when they were hurling toward the earth without any way to control their ship. It feels maybe a little bit like that since we're seeing the Medicaid transformation plan coming to an end. But I just want to remind the board that we have time. We have time to really plan and consider our future and to refine what we're doing to respond to the real needs of the community. So while we have this retreat and this opportunity to talk about the future today, I just want to give everyone assurance that we have probably more time than we think we do to put together something that's really thoughtful, that does address the needs of our communities and our providers and our stakeholders. So we thought, first of all, we would start by reviewing the highlights from our board retreat on April 19th, 2019. You might recall that the board went through several visioning processes way out to the year 2030 and even 2040. So we try to envision our future state for providers. What would that look like? What would that feel like? How would we be addressing the social determinants of health and health equity by 2030 and 2040? And then finally, as a whole, what does GCACH look like? Next slide, please. So these are the takeaways. These are taken straight from the notes of our retreat last year. You might recognize some of these statements because many of you made them. So you envisioned for the future provider organizations by 2030 that your organizations would be stitched together so that you would have your primary care and your specialists, your pharmacies, your behavioral health. You would be working together, stitched together for better care coordination, collaboration, and more partnerships. And this could happen internally and externally so that there would be better communication flow, access to providers, referrals and wraparound services. Next slide, please. I think it was Sandra that talked about telehealth and the expansion of mobile health. That's already happened because of COVID. So that's not even by 2030, it's something that's happening right now. But you also said we needed more flexibility in care and delivery and access. We needed to close some of those arrangement gaps and hopefully lower that total cost of care. Next slide. You wanted information management tied to action so that, Eric, this was right out from your words from your mouth, is to get information from EMS to providers and providers to providers so that there was this creation of a record, a patient record that not just was a medical record, but it was a community record that people would understand, where people were at in the system, that these arrays of services were broadened and expanded. Next slide, please. For the future state of organizations, you wanted to be meeting people where they needed help, whether that was care coordination or case management or peer support. Next slide. By 2030, the board envisioned that providers would be integrating tools to address the social determinants of health so that you were moving beyond the concept to actually practicing this care coordination, that these tools are top of mind and that you were integrated with provider organizations, and that CHWs, community health workers, and community engagement was a natural part of that system. Next slide, please. You envision that public spaces and services and supportive housing would be addressed as part of people's health, and that an array of services was broadened and expanded to address the whole needs of people. Next slide. One of my personal visions was that there would be accountability for our local decision makers on addressing the social determinants of health, such as affordable housing, education, transportation, and these days we're adding racism, dismantling structural racism as an important element that we really need to address. Next slide. And that there would be incentives for all key players. Next slide. So the future state of the Columbia region, the greater Columbia region, included community engagement and education and primary prevention and treatment and moving upstream. Next slide. Finally, the board had recommended really 4 areas, is that the ACH turns into a center of excellence, that we implement a fee-for-service consulting model, that our lines of service were around practice transformation and care coordination, and that we continue to convene community-based partners, stakeholders, our local health improvement networks to address social determinants at a regional level. So what have we done, next slide, since that time? GCACH staff have done quite a number of things to prepare ourselves for today. We have done a market research that you will hear Lauren talk about a little bit later. We've talked with ACOs and subject matter experts. We did an internal and external interviews to identify our core strengths. Chelsea did an in-depth sustainability plan and used these interviews to inform her plan. We hired Simi Bird, who's an organizational consultant, to do a staff assessment of our emotional intelligence. The 3 characteristics of a high performance team: self-actualization, interpersonal relationships, and optimism. And Simi said that as a team, we have a higher emotional intelligence and balance than most organizations do, even in our infancy as an organization. So that gave us a lot of encouragement. We held a staff retreat with Tenfold Health that the board approved to test our sustainability plan and our opportunity thinking. We since then have had a one-on-one vision and sustainability discussion with the Healthcare Authority. The ACHs have been working in concert with the Healthcare Authority on a social investment model concept. And we have since learned just very recently that there is a possibility of a 6th Medicaid transformation project year for all the ACHs. Next slide. And finally, we looked at possible models for our future state. And so part of this discussion today is whether we go forward perhaps with a fee-for-service consulting model for practice transformation, that we act like an ACO to receive a portion of shared savings. We have direct contracts with the Healthcare Authority, Centers for Medicaid and Medicare. We already have a contract with the Washington Rural Health Collaborative. Maybe there's possibility of contracting with WSHA, even perhaps MCOs and other state agencies. There's always the possibility of having a membership fee model like the Washington Health Alliance. Of course, we are going to start vigorously pursuing grants, and perhaps there's opportunity with other ACHs to find funding. Next slide. So who is GCACH today? Just a reminder of our vision and our mission statements, and Lauren's going to be covering this during our discussion of marketing, but it's our mission to advance the health of our population by decreasing health disparities, improving efficiency of our healthcare delivery system, and empowering individuals and communities through collaboration, innovation, and engagement. And ultimately, the vision is that we will become a vibrant, healthy community in which all individuals, regardless of their circumstances, have the ability to achieve their highest potential. We are trying to stay on track, Patrick, so I think we will reserve some of these comments and questions for the end unless there's something burning that the board members want to contribute at this point.
Yeah, Carol, I was just going to suggest that this is kind of a teeing up presentation and a high-level overview, and I think that's probably a good idea just to wait until we get to the more general discussion. But if others have a burning question or they want to point out a typo, let us know right now.
Okay, so we will move on. Today we're going to be talking about the Greater Columbia ACH's core competencies, and we have worked for a year really to try to uncover what those core competencies are. Some of them were discovered last year during our retreat, but we do think that these 3 really are the most outstanding as far as we have analyzed. That one of our core competencies is being a consultant for integrated primary care systems. Sam and Martine are going to take you through that competency. That we're a connector for local, state, and government entities, really a catalyst for thought leadership and change. And Diane and Chelsea are going to be talking about some of those competencies and opportunities. And that we're a champion for health equity and social determinants of health. And Wes Rubin will be taking us through that exercise. So talking about the consultant for integrated primary care system, I think that's the next slide, will be Sam Wardell, who's our practice transformation director, and Martine Sanchez, now one of our veteran practice transformation navigators.
Hello and welcome. So for element 1, we'll talk about the consultant for integrated primary care systems. GCACH is a consultant for integrated primary care and assists healthcare professionals within organizations to ensure that the Greater Columbia Cares model, which is the GCCM, is effectively implemented within their systems, culture, and practices. This GCCM model, I have to say, is really catching on. The terminology currently had 2 interviews with the Department of Health and Washington State University for 2-hour implements, and they're really interested in this evidence-based model. Next slide, please. So go ahead, Martine, I'm sorry.
Sorry. So these are the current strengths that we have as, as an organization and as practice transformation navigators, what we are able to provide to our providers. We do personalized technical assistance, which includes, workflows, either creating new workflows or looking at current workflows and seeing where we can improve. There's also, we've been able to help our providers get hooked up with collective medical, which they are able to track their patients that have been in the ED or have been hospitalized. And other technical assistance that we are able to provide is the implementation of screening tools, whether that be a PHQ-9, GAP7. There's different screening tools that some sites have implemented with the help of us. We have also helped our sites identify shared decision-making tools, whether that be medications and diabetes, giving them options as far as, what type of treatment they want to receive. So getting the patient more involved in their care. The 6 building blocks, that's another thing that we are currently getting trained on, and we are going to be able to assist our providers with that. We have the expertise in PCMH certification, the toolkit and gap analysis. We're able to do that. We're currently also getting training to become certified content experts in PCMH, which that will help our sites, for those that want to be certified in PCMH. We're able to help them through that journey, which the sites that we're currently working with are in that journey using the Greater Columbia Cares model templates, which, that will get them to at least a level 1 certification in the PCMH-A. And then the work that we are doing, it's based on the PCMH Foundation. So on the 8 pillars of the patient-centered medical home. We have also expertise in billing and coding for services that maximize reimbursements. We have Sam with that knowledge. We have been able to help providers, be able to get better reimbursements in services that they are providing that they didn't know they were able to get, enhanced reimbursements on. So we're helping them with that as well. And that will help for sustainability within some part of the organization. So getting in that extra money for the services that they are providing. Credibility with other ACHs, the Healthcare Authority, and MCOs and other state agencies. This is a big part of what we do. We are currently working with the Washington Rural Health Collaborative with sites around the state. They're out on the coast to close to Idaho and then down to Goldendale. So it's pretty much all over the state. We have also hosted other ACHS navigators because they were planning on implementing navigators as part of their work as well within their ACHs. So they came over and shadowed us for a couple of rounds. We have meetings with the Healthcare Authority and the MCOs and the behavioral health providers that we work with, and they listen to issues that they're going on within their agencies and seeing how the MCOs and the Healthcare Authority can provide assistance to those providers. We have also establish relationships with other providers, which you guys, have seen and have read our stories in our monthly newsletter, where, you guys see the outcomes that, the work that we are doing is having in their patients and also within their sites. They've been able to implement a new EHR or a population health management tool. So, that builds trust, and they highly trust our feedback that we give them. They don't take it in a negative way. Rather, they take it in a more, okay, these are things that we can improve on. Let's work on them. And there's hardly any pushback from any of the providers. And there's also established relationships with or expertise in PCMH planning and implementation. Again, that's the Greater Columbia CARES model that's based on the PCMH Foundation, on the 8 change concepts. So we're able to plan and assess, where the sites are. Okay, for the patient-centered medical home assessment, these are the areas of strength and these are the areas of opportunity. How can we amplify your strengths and also bring that, that work down to the areas of opportunity and get you guys up and running, and, accomplish small goals within those areas of opportunity. Next slide. Toolkit that can be adapted for individual organizations. Those are, the Washington Rural Health Collaborative. That's a good example. They're not doing the whole toolkit or all of the milestones, all of the 8 milestones in the toolkit. They are only focusing on depression, diabetes, and hypertension. So we tailored the toolkit, the British Columbia CARES model toolkit, to model, the work that they are going to be doing. So we were able to customize it to their needs. There's also a successful model for standardizing approaches to care. There's population health management that we have been able sites to help, to get them to know their patient population, which are more at high risk of, using, more resources. Let's pay more attention to those before, they get any sicker or they, they use up any more resources. So trying to be more proactive in identifying those patients. There's billing and enhanced reimbursement that I talked about earlier, that are successful models of things that have been implemented. And then there's the clinical quality metrics that, our sites are supposed to track. Again, things that are meaningful to them and that will achieve, better patient care within their patient population. And lastly, expertise in solving issues at the organizational and individual levels. This comes to the practice transformation assessments. We try to get a quality improvement team in place that has a representation from different sectors of their sites. And we're able to solve issues with the leadership that's in there. They're able to provide guidance, and they're also, the ones that are making those decisions that are trickling down to the providers, to the medical assistants, to the front desk. So that's how we're able to bring the group together and solve issues either at the site or at the organizational level.
And the needs and opportunities, expansion into other regions and states, which we've already been able to accomplish that by being a part of the Washington Rural Hospital Coalition, which is the HRSA grant. We've heard great feedback, and you'll see that in some of the different slides with our initial assessments and implementation processes. Expansion into other payment models, commercial insurance. And as you're well aware, the GCCM model is for all payer types, not just Medicaid, even though it's a Medicaid demonstration. Extend capacity and credibility by bringing a physician on board. Continued development of current navigators, as Martine had already mentioned. Advocate to increase the statewide emphasis on the value of primary care in the PCMH model, as well as building off the other evidence-based models as well. Next slide. Promote GCACH as more than just PCMH. And anyone that's involved in the GCCM model knows that there's many implementations, since there's no key turn approach to any organization or any clinic within that organization. Just reimbursement models for physical and behavioral health providers. For example, the BRE Collaborative, maybe it's a bundled payment, or maybe it's under the pay performance values. Continue to refine the toolkit and processes for practice transformation. Again, no key turn approach, so making sure that we're really understanding the needs of those different clinics and organizations. Next slide, please. Providing learning opportunities focused on practice transformation. And I can tell you, being on many work groups for the state, that the physician's voice is really not heard. However, with the GCACH, we really do try to focus and hear what the providers, what their needs and training opportunities are really required for them to be successful. Developing our process reports and measures, for example, the dashboard for the CSI portal. Provide subject matter experts, such as Mike Hindmarsh, and bringing on different collaboratives in order for us to be successful on meeting the milestones, but also in order for us to be able to give you the expert in the successful implementation of these milestones with resources. Toolkit is important. Need to promote and support organizational cultural change within organizations, via leadership, provider burnout, and quality improvement. So really building those team concepts, building those QI teams within the organization, and really becoming involved and having that leadership to really promote that and give ample opportunity with resources and time in order for them to be successful. Next slide, please. Next slide, please.
No,
And at this,
Sam, we just want to take some time here to
okay.
to have the board members respond to what you and Martine have just gone over.
Okay,
So,
I didn't understand that. I thought we were going to wait till the end, so I'm sorry.
No. After each of these presentations, individual presentations, we just thought we'd give a little moment and ask if there's questions of clarification, or if you have questions of interpretation, or if you agree or if you disagree with what you just heard in what is really kind of a mini SWOT analysis on the part of Sam and Martine. So any quick comments from those of you on the board to this first area of expertise that the staff has identified? It meets with your approval, perhaps, but it doesn't have to. So we just wanted to give you an opportunity. We can talk a bit later. So.
Yeah, this is Brian. We've had a little bit of conversation about this previously, but at least I have. I like the idea of like we've talked about, the expertise in planning and implementing the PCMH models as we go forward. I like the idea, it's kind of out of the box thinking when we start talking about expanding out of the region and into other states. I think that's a much bigger vision, frankly. That's going to take a lot of I guess imagination is a good word to figure out how to do that, but I like it. I think it's where you got to start. So it's kind of big thoughts.
Okay, thank you, Brian. Yeah,
that's kind of where I'm at with it.
Any other questions or comments follow up on what Brian just mentioned? Eric?
Thank you.
Can you hear me?
Yeah, we can hear you.
Finally, my microphone decided to work. No, I like what I'm seeing. It's well thought out and coordinated. It looks good.
Okay.
I'll be honest with you, I'm relying on you guys. You're the subject matter experts in this area, and I don't see anything that's problematic in my thinking.
Okay. All right. Does anybody, any board members need clarification or a little more explanation of the GCCM activities that both Martine and Sam referenced? Is that clear to everybody? It really is serving a bit as a model for how we might move forward.
Yeah, I think we should speak more to that.
Okay. So Sam, could you tell us a little bit more about that? I mean, I'm all ears as well because I don't know that much.
Yes, so the Greater Columbia CARES model really builds off the PCMH, the patient-centered medical home model. However, it's transformed into a lot of other different initiatives. It incorporates sub-best practices for the IHI, which is the Health Improvement Network, the Comprehensive Primary Care Initiative, which is CMS Medicare Services Initiative, 6 building blocks, Safety Net Medical Home, the AHRQ, which is the Agency for Healthcare Research and Quality, and the Robert Wood Johnson Foundation, Cultural of Health. We're finding that when we go into these organizations, there's lots of needs, and just building off of one process doesn't necessarily meet the needs of the patients, whether it's chronic illness or medication management, or just the simple processes that come into evidence-based models of the primary care. Dealing with these different organizations, it really takes a compilation of all of these different initiatives in order for these different organizations to be successful, and really being able to give them a smorgasbord of resources and items in order for them to be successful to meet these milestones, but also to be successful in the state initiatives as well as the government initiatives.
Okay, and you've applied or brought these to some of the providers in the Tri-Cities?
Yes, we have actually implemented the majority of these different initiatives, and the navigators are really trained and robust in these areas, and being able to explain and look at these assessments and what might be successfully implemented within these organizations, and provide those resources and facilitate those resources and implementation.
Okay, and how long has this been going on, and what's the feedback so far?
Martine, you want to take that?
Yeah. So practice transformation has been going on, working with sites going into 2 years. We have 3 cohorts. So cohort 1, which started at the beginning of 2019, they're in their 2nd year right now. Cohort 2, which is made up of the behavioral health and substance use providers, they started mid last year, so they just completed their 1 year last month. So they're in their 2nd year. And cohort 3, which is made up of a combination of hospitals, primary care, behavioral health, skilled nursing facilities, they're in their 1st year in their 2nd quarter. And for the 1 year sites, we have seen great improvements, better population health management. They have implemented different tools within their EHRs, that makes the work easier on them, less manual work for them as well. And then, for the behavioral health sites, this has been wonderful because we have, provided different tools that they're able to use. We've gotten them connected with One Health Port, which is the state's data repository. They're getting connected to Collective Medical, so now they're able to track, the patients that have been in the ED and have been hospitalized. And we get them connected to other sites that are part of practice transformation, just to see how they are doing a specific process, and seeing if they can take that back and implement it within their sites, or seeing how they can tailor that to make it fit for their organization. And all that, it's so far we've only seen great outcomes. There are some things that take a little bit longer to implement, either because the infrastructure is not there or the resources are not there. So we look at okay, what do you have available now that can get this accomplished? Can we shift some of the work around? So, making sure that people are working to the top of their licensure. That way, maybe what a provider is doing, a medical assistant or a nurse can do, freeing up, more time for them so that they can spend more time in patient care rather than, let me, do something that something else can do. Those are some of the things that we've seen out on the field, as well as, hearing the success stories that, you guys get on your monthly newsletter.
I can tell you that the University of Washington, they commented that it was the PCMH model, the patient-centered medical home model on steroids.
Okay, you're referring to the GCCM. Is that what you're doing?
Yes, sir.
Okay, all right. Further questions of Martine and Sam on whether it's the GCCM experience or whether it's about the proposals of where they might go forward. Could you just cursor back? We've got about 4 or 5 minutes here. Chelsea, could you just cursor back to sort of the opportunities and needs slides? I think there's 2 of them. Yeah. Okay. So any more thoughts on needs and opportunities for this consultancy role of the ACH?
This is Sandra. Not a question, but really just a comment based on something that Sam briefly talked about when she said that they're, going onto new sites and they're finding that they need additional assessments. I think they're before some organizations and even some organizations that are in the PCMH process, there is still a need for some needs assessment work that needs to be done, which I think staff would be really excellent at capturing, because a lot of organizations can't always afford to do some of the assessments that they need. They do certain level of needs assessments, but like there are other assessments, especially when we start to expand PCMH to include more of the social determinants of health stuff. Like, how many organizations have never done a culturally and linguistically appropriate services assessment? The class survey is huge for a lot of organizations as we move into the SDOH arena a lot more. And I would just like to throw that out there. Maybe that's something that we also should add to that, is helping people conduct assessments that maybe they don't know that they could be doing, to look at how they could improve their services as they go along the PCMH, because there's a lot of quality stuff that we all kind of know as healthcare providers that, it gets kind of beat into our head, but the social determinant stuff and some other assessments that, you wouldn't catch on a MEHAP, you wouldn't catch it on a PCMHA survey necessarily, might be really attractive to a lot of organizations.
Okay, so yeah, I was thinking whether that goes under this element or whether your suggestion would fall under the elements that are about to come up. But you were talking about actually working with clinicians to make them more aware and help train them about the social determinants opportunities that might help their patients. Is that correct?
Yeah, and it's not even just, that's just one example off the top of my head. I think there are other, assessments that people can be doing, like looking at, where are they meeting their patients? PCMH covers some of it, but it really doesn't cover all of it. And I think there are other assessments that people can be doing when they look at their organization and the scope of their work, especially when we talk about integrating services. That's integrating different service lines into an organization can be a really tough one. And a lot of times when I've been at different organizations or worked with different organizations, you kind of see like there's always that sticking point, and they really need someone to help facilitate and pull up that data. And I think being able to draw together some data and do some deep diving with an organization about their data and information, I think those are really good strengths of the staff and things that they could be doing that are value that someone would pay for, to help with the sustainability of the organization.
Okay. Chelsea, I don't know if you took notes on that, but if not, we can come back and do that later in the session. Thank you, Sandra. Any other comments? Just looking at this slide and needs and opportunities, and can you go on to the next slide?
Patrick, can I add just a comment to Sandra? And I'd love to work with Sandra on some other guides that she might have available. But so our navigators have been trained on the care transitions and assessments, as well as community health workers, the paramedicine, chronic care, the BRE. Of course, you know, the MEHAP, the PCMH, and normal ones, but then also the health literacy toolkits. They use that as a guide for assessments and implementation, telepsychiatry. So there's several toolkits and implementation assessments that we use, but I'd be happy to hear more about that. Thank you.
Okay, Sam, thank you. Yeah, it seems to me this would be an opportunity that we could add here. All right. Anybody else have some comments to these suggestions on this slide and the prior slide? I will say, go ahead.
And I just, with respect to this element, I think myself and then in consultation with the other managed care organizations see this as a great opportunity for GCACH. I think I've shared in the past that this is an area where we believe that Greater Columbia has shown its strength and is perhaps unique and a leader of the pack, and at least being sort of their transparency around sort of this approach and effort around practice transformation. I think there's some recent developments around the multi-payer primary care initiative that was released to the public back in June, and as we're considering what that looks like, I think there's a sort of question around sort of how and where are providers receiving some of that consultation and transformation support to be able to meet the expectations. And I just think that it may be well positioned to be engaged in that space and supporting providers along with, and again, sort of aligning with that commercial space. So as we're looking at multiple payers participating in that approach and aligning around those expectations and components, I think that this work around practice transformation could just really flourish and be needed in that space.
Okay, thank you, Kat. It's good to know that we have some experience in the Greater Columbia with a multi-payer model, because this is, of course, a Medicaid transformation project. But we know that in most, on average, I think the Medicaid patient population constitutes about 25% at the most of total patient rosters. So yeah, getting other payers involved successfully would be something that if we could succeed, that would be very important. We just got the 2-minute warning. So any final thoughts on this element 1 as basically a consultancy role for the GCACH? All right. Well, hearing none, we will probably circle back. We will circle back to a little further detail, and Kat, your comments here they're going to resurface after the break. So I hope you'll be able to give us a few more thoughts. With that, Sam, I'd like you to introduce the next set of speakers for element 2, or Martine, one of you two.
Patrick, we're actually set for a break right now from 9:55 to 10:10. So we have about a 15-minute break right now.
Oh, the break is going to be this early. I was looking at that and I didn't realize that. That's okay.
We could adjust, Patrick, if you think that people would be willing to do the next element and then take a break after the next element.
I actually think that would be better, because we're
Okay.
only 1 hour into this, and
All right.
typically, you take a break in the middle, right? So we're not in the middle.
At this time, I'd like to introduce element 2, connector for local, state, and government entities. It's Diane Halo. She's our ORN project manager, and Chelsea Chapman is our admin assistant, but so much more than that. So welcome.
Thank you, everybody, and thank you, Sam. So for element 2 for Greater Columbia, we see ourselves now and in the future as a connector for local, state, and government entities. And so what that means is that we are a conduit by which other entities, organizations, individuals, groups are really able to effectively get together, collaborate, launch projects, gain insights, share ideas, and really shape policies that will make an impact in the future.
So this is Diane, and I'm going to talk about this section because it's something that I really work on and something that I am proud to talk about. So our current strength as a connector for local, state, and government is that we have the ability to collaborate environments. GCACH builds networks. We have a lot of committees, and we create action by engaging with community leaders, experts, healthcare workers, and other professionals to collaborate, share, and take part in creating change. We serve as a broker by understanding the players across the different systems and making those connections. In some of the examples for this is our GCACH behavioral health provider meetings that are monthly that connects Healthcare Authority, the managed care organizations, and the ASO, and all the providers together so that they can discuss issues and concerns that they may have. The supportive housing initiative to the continuum of care, our local health improvement networks, as well as our opioid resource networks for the medicated assisted treatment for patients with opioid use disorder. They provide wraparound care. The next one is the ability to make connections between all the different systems. The different systems that we work with are the managed care insurers, social services, education, public safety, public health, housing, transportation, behavioral health providers, primary care providers, and also hospitals. The next one is that we have experience in convening to address community needs as well as providing education and outreach. And these are our learning collaboratives, our community resilience campaign. We have done a lot of initiatives around with the COVID-19, the masking campaign in Yakima and Benton Franklin counties. Next slide, please. And then the ability to bring in national thought leaders. And this is one example is the Trauma-Informed Care and Opioid Summit, where we had Vincent Paletti and many other national well-known speakers come. Other thought leaders and subject matter experts that we've had is Allison Massari, Adam Falcone for contracts and negotiation, Mike Hindmarsh for chronic care, Karen Hill for complex care, and then Ken Crable for trauma-informed care and provider burnout. We've had the ability to deliver community mobilization. For example, these are the things that we've done with COVID-19 with the masking campaign and the distribution of 840,000 masks that were provided by FEMA, and then also our skilled nursing facility care packages that we've been able to do. Next slide.
Thank you, Diane. So there are several needs and opportunities with respect to being a connector for local, state, and government entities. Some of these, or one example is being a key component for coalition building and movement building between groups across many sectors. This includes disseminating education and useful information through our learning collaboratives and leadership councils, as well as providing the platform to connect and collaborate. Another example is serving as agents or local representatives for healthcare authority. So we do this currently through our BH providers, MCO HCA meetings, as well as serving for essentially the go-to for providers in other entities when it comes to relaying information upstream or even downstream. Supporting local health, collaborate with other consulting groups and experts to enhance current resources. So making sure, we're not reinventing the wheel, that we're leveraging the resources and activities that are currently going on in our region, and, trying to, make sure that we are friendly to play with, so to speak. So we want to make sure that we are work with others and collaborate effectively. Supporting local health improvement networks through our connections, resources, and abilities to facilitate change. Providing community support for other groups or organizations who need it. So, for example, we help the group supporting the supportive housing initiative, otherwise known as the continuum of care. So by letting them use our teleconference platform to host some of their meetings before they have their own account. So really trying to be an avenue or providing, leveraging our resources for others to, regardless, meet the mission. We all have a mission that we want to achieve. How can we best help support other people as well? Next slide. The need for friendly data is always an important factor, and so we have the ability to collate and curate data that is useful. So, for example, the data captured in our newsletters and GCACH reports and our annual report, and even to the leadership councils. Earlier this year that we had presented information and data on the COVID numbers in the region. So really just making that data relevant and communicating it effectively. Lastly, there's the connect local and regional leaders around complex issues. We've done this in the past with our community resilience campaign, our COVID masking campaign, and then our assisted living campaign. And then we have here a really nicely articulated statement from West Lucky, and it reads, our mission is for transparency, to help people understand the disparities in their region and across regions so that they can see where there are gaps and opportunities. We bring them together to help resolve those without being the resolver. We are there to help facilitate that process so that the local health delivery systems can take on that work.
Well said.
That's from all of the GCACH.
No, so that's a direct quote, Wes.
All right, so that was once over lightly this major role of convening, coordinating, facilitating, encouraging. And I just wanted to add something that as I was seeing this for the third or fourth time, that struck me, and we certainly wrestled with this in the early years of the ACH, and that is, this is work that has gone over 9 counties, of a real swath of geography in our state, which isn't and hasn't been easy. But I think you board members may disagree with me, but I think the staff has risen to the challenge and getting quite used to being in Clarkston one week and Ellensburg the next, and all the places in between. So that is not, from my experience, an easy thing to do, even within one community the size of, say, the Tri-Cities or Yakima, let alone all the different communities that the 9 counties really are composed of. So I just wanted to put that out there as a, I think, a unique role of the ACH in that it has been able to, I think, bring communities closer together and perhaps eliminate some borders or boundaries that were there a few years ago. Anyway,
Hey, Patrick.
Enough of my stuff. Yes.
So I wanted to make another comment. This is Diane. So one of the things that I also wanted to talk about in this section is that the leadership of GCACH has been reaching out to all of the local government officials, and we've met with almost all of them now, and giving them a PowerPoint presentation, letting them know what we're doing and how things are going in the areas that they serve, and it's been going really well. I just wanted to point that out as well.
Sure. And I know we have a county commissioner on the board, and I hope that has been appreciated in Yakima. Okay, so let's go back to a couple of those needs and opportunity slides and ask the board whether you have comments, questions, concerns, additions, and perhaps anything else, because we do have a few minutes here.
Patrick, this is Eric.
Yes, Eric.
So a comment and a question. So yesterday, I was asked to present our falls prevention program to yesterday was its very first meeting of the Violence and Injury Prevention TAC out of the Department of Health's EMS and Trauma Services Division. And a lot of really excited people who saw a program that with some work could be scaled to operate in communities all around Washington State. But it occurs to me as I'm sitting here listening to Diane and Chelsea, which by the way, great job. And I like what I see here. But what occurred to me as I was listening to you is that I've been on TACs with Washington State for years. And it's the same people, the same players. It's the Department of Health. It's the local EMS and trauma services. And it may be a few other ancillary players here and there. But I've yet seen an ACH present at any of these meetings. And as I hear you, you know, if you really want to connect local and state government and be that that player that helps, you know, grease the wheels or the gears or whatever and make these things happen, especially when the state is looking for best practices that can be scaled from one community across the state. I really think we got to figure out how we can get you guys, all the ACHs, involved in these TACs. And I'd be interested to hear your thoughts or concerns with that.
Yeah, thank you, Eric. So response, Diane?
Sure. I think that would be a great opportunity for us. I know that, you know, we've had other opportunities to be part of different organization committees and such. And so all we just need is an invitation. Forward us the invite. We'll go, and you know, and then we'll see if there is a way that we can participate. That's, I don't know what else to say. Maybe Carol has. I know that we're trying to get into more committees throughout the state. Carol's on some, Ruben's on some, and you know, if we can, you know, get invited to these meetings, that would be awesome.
Diane, thanks for the kind of the lead in for that. When we talk about these different elements at our Tenfold Health Retreat with Chris Keller and Mike Bonetta, they really challenged Greater Columbia to say, what is the problem that you guys are trying to solve? You know, with these three elements that you are presenting, what are you trying to solve? And I think what Eric is describing is part of this problem of our healthcare delivery system is that we're all siloed. And I think that's one of the strengths of Greater Columbia is that we can bring those silos together and work across sectors. And I think Lauren's going to talk a little bit more about that. But really, when you even just look at our government structure and who the board represents, you guys come representing 17 different sectors of our healthcare industry. So part of the problem of our healthcare industry is being solved by GCACH playing that connector role. Sometimes, Eric, we're not invited to the table, and we invite ourselves to the table because we see a gap in the system of care for the community. So we'd be more than happy to participate. I think this is a great idea. Local health jurisdictions have typically taken on fall prevention. Right now, they're pretty tied up. So this might be an opportunity for Greater Columbia ACH, and we don't want to step on anybody's toes, but I thank you for that, that thought.
Yeah, well, I can work on getting you a list of all of the different TACs that at least impact my corner of the world, and you guys tell me which ones you think you could have a greater impact on, and I'll get you an invite.
Thank you.
Thank you. That's great.
Thank you, Eric. That's a great suggestion. Other board members' responses. reactions to what you see here in the next 5 minutes. Coalition building, agents of the healthcare authority, collaboration with other consultants, obviously the LINs, convening support, and so on. Is this something we can expand on? Is this something, as you'll hear later, that we can actually sustainably continue?
This is Kat, and if you could you go back to the slide before, Chelsea? I think the role of coalition building and movement building is one that is really critically, and I think the recognition of sort of what tables are forming and happening, and sort of how the ACH can be engaged or be the table for those conversations is really important. And I think it's where there is a unique opportunity with the ACHs, and why I've sort of believed in the idea of collective impact and having sector representation for a very long time with respect to how we move this forward. There's a really interesting article that recently came out about collective impact in Milwaukee, and how a group in Milwaukee that has been formed around the tenets of collective impact have really responded effectively during times of crisis, especially with COVID. And I can circulate that article, and I think that that's something that, again, I think could be elevated and sort of considered, is that we, in times of crisis, have to work quickly and have to work together. And so as there are opportunities to break down those silos and continue to sort of facilitate that shared responsibility, I think we need to consider ways that we can promote that. So I respond well to that, and like I said, I can circulate that article. I'll try to find it and maybe put it in the chat link. I have a little bit of a sort of interesting reaction to the agents and local representatives of the healthcare authority. I think, again, sort of in that similar space, the healthcare authority is just one agency, and while we know with respect to the leveraging of the Medicaid transformation waiver, it has been the contracted entity for the healthcare authority. But I think that as we consider to think about sort of who and what the Greater Columbia ACH is, I wouldn't want to limit it to that representation or sort of that connection point, but recognition of, if we have multiple sectors within a regional space, how are we ensuring that there's multiple sector connection at the state level as well, so that we can really kind of facilitate that shared collaboration at the state and regional level. So that one, I sort of have a little bit of a, like I said, sort of interesting reaction. And if you can see me on video, it's sort of like I don't know, I raise my shoulders and maybe kind of give a little bit of a weird smirk, I don't know, face. So giving you a little bit of an image, like, I'm not really sure if that's exactly right, but I think I really respond to the coalition building and collaboration.
Okay, good. We're going to come back to that thought or that general area, Kat, and then I'll probably challenge you with a couple more details to that, and like to learn more what your thoughts would be. We've got just a couple of minutes before we break. Any other thoughts to this role of the Greater Columbia ACH as a connector? You happy with it? Is this something that you would like to see carried forward by the staff?
So Patrick, I just want to interject one thing about this connector role is that we're already seeing things happen as a result of our connections. And I'm glad Kat brought that out about, it's not just the healthcare authority, it's the Department of Health, it's the Behavioral Health Institute, it's the broadband committee, it's the Department of Commerce. It's, we're not just, I think what we saw is that we could be agents for healthcare authority just because of the Medicaid population, but I'm glad that she pointed that out. But a good example of our connector role really working for us is that I'm part of the Behavioral Health Institute Strategic Oversight Committee. I think, Kat, I've seen you on those calls too. As a result of that work in telehealth and the promotion of telehealth, we've been able to take that message to our decision makers. And just yesterday, we met with Congressman Newhouse's Representative Aaron, and he was saying how Congressman Newhouse is really behind this whole telehealth effort. So we've been able to be a part from the very beginning of implementing and facilitating and delivering dollars to providers to implement telehealth, to then creating the policies that will ensure its survivability beyond COVID. So I think that that's just another one of those lines, those threads that we have been able to weave from our role as the ACH into policy and being a connector then of all of these different organizations that are able to take advantage of that.
Good. I'm glad you brought that up, Carol. Last minute comments from the board before we break. Again, we'll have an opportunity to come back and be a little more specific about this. All right, so let's all head to Starbucks for the next 15 minutes and come back with coffee cup in hand, and we will hear from Wes and Ruben on health equity and the social determinants of health. So see you in 15 minutes. Chelsea, are you there?
Oh, sorry. Yes, I was just about to say time up.
Yeah. So I don't.
Hi, Patrick. This is Loanne.
Hey, Loanne. Can I call you later on today?
Yes, hearing your voice reminded me that I owe you a call. I'm swimming in craziness. Does that sound like everyone's normal now?
I think in particular for you, but probably for most of the people on the line. I don't know if that's for me, but working from home and just doing things remotely isn't as hectic as I think a lot of people who are on the board deal with daily. So shall we get started, board members? I guess we don't even know whether you're back, but we have to assume that you are, since we're not showing the videos or the webcams yet. So this is a presentation on the third leg of the stool that the staff has come up with as core activities or elements of the GCACH currently and perhaps going forward. And this will be presented by both Wes and Ruben. So why don't you guys take it away?
Thank you, Patrick. So yes, GCACH is a champion for health equity and addressing social determinants of health. And that's why for the last 2 years or so, we have used our resources to bring about, to break down barriers and to bring about some innovative steps and changes to address those two categories, social determinants and health equity. Next slide, please, Chelsea. So one of the things that we have done is develop and organize effective community campaigns. And as you might remember, the ACEs and Resilience campaign pilot we conducted in Yakima from January through March. We convened a task force from members from throughout the 9 counties that helped put this together. It was a successful campaign. It was an educational and awareness campaign. It had the awareness campaign was mostly media through just about every platform, and the education campaign was in-person trainings with professionals who work with families and children. We only got to do 2 in-person trainings out of the 3 scheduled because then COVID hit in March, so we weren't able to have the last one. So we had that campaign, and we're put a pause on it for now while we deal with this current situation. And also, another campaign we are working on is the supportive housing initiative. One that comes to mind is the one we have here in Pasco, which we are still working on, and hopefully deem it a success this year, or as soon as possible. Another campaign that's currently running is the Spanish masking campaign that the Benjamin Franklin County asked us to conduct. They felt that, and they were right, they felt that there was not enough Spanish communication in regards to masking and COVID, and especially local communications that the public can identify with, local people or local landmarks that people can say, hey, that's speaking to me. So we do have this Spanish masking campaign running on Spanish radio, Spanish TV, and Spanish social media. We convene a group of local leaders in the healthcare field and some Spanish-speaking leaders as well, and we decided to build on a campaign that the local director of the Downtown Pasco Development Authority had run for Father's Day in June. So he was using the theme of lucha libre, the Mexican wrestling. If you remember the movie Nacho Libre, where the wrestlers would wear masks, and so we picked up on that, and the campaign, the media, the ads that are running have an element where a bell sounds at the beginning of the ad, and people, the community leaders, and some other people that work in certain essential sectors, they invite people to. They tell the audience why they are fighting, which lucha means fighting. One of the meanings is fighting. Why they fight, who they fight for. It can be mom, dad, it could be the community, it could be businesses. And that's why I put on my mask, they say. And then they put on a regular COVID mask, but it has the sign of one of those Mexican wrestling masks that are easily recognizable, but most people that are from Latin American descent, I wore one time to McDonald's, and the people right there recognized it right away. So that's one. That's another campaign. Plus, not to mention the 800,000 plus masks that we are distributing through our communities. We have earned the trust and goodwill of many partners throughout the 9 counties. We have collaborated with many, including the local health improvement networks, the Yakima Nation, elected leaders like Diane mentioned a few minutes ago, and also third-party administrators. And I'll speak about this later. Also, the third-party administrators. These are 4 foundations throughout the 9 counties that helped us find the grantees that are currently addressing the social determinants of health from the Community Health Fund that we set aside to address those social determinants. And we developed data-driven models for equitable distribution of these resources, and we set aside $1.4 million to address social determinants of health. We asked the local health improvement networks to help us find what are the most present social determinants in their communities, and they use mostly a survey tool to ask their local Medicaid consumers what is it that is the biggest challenge to reach health and to maintain it. So they conducted surveys throughout the 9 counties, mostly in healthcare providers, and they came up with each region's biggest social determinant of health, which the most common ones were housing, food insecurity, transportation was a common theme throughout, and mental health. So we then contracted with third-party administrators to issue requests for proposals, and they selected those organizations. And right now we have 30 plus people, organizations doing this wonderful work, and I'll name a couple of them later in my next slide. So we use, for us to allocate, going back to the data, for us to allocate the funding, we use the Robert Wood Johnson Foundation county health rankings, and we decided to put a share of the amount just divided based on Medicaid population. A share of the amount was divided just across based on Medicaid population, but the other share we based it on how healthy each county was, and the most unhealthy counties got a little bit more. So they ended up, especially rural counties, they ended up getting more per Medicaid consumer than some of the counties that have a larger population. So we were looking at equity there, because rural counties have challenges. So yes, I'll hurry up here. And the next, and the pilot, really quick, the pilot we run in Yakima in regards to ACEs, we used OSPI information and DSHS, and as well as the Robert Wood Johnson Foundation. So every decision, everywhere we place resources, it was data driven. Wes?
Next slide, please. So since the beginning, the ACH has identified several data sources and has done research and analysis that has evaluated a number of different areas, such as the availability of different provider types, like capacity in primary care, behavioral health, oral health, and others. We've also looked at pay-for-performance measurement outcomes, comparing our performance against the state and against MTP targets. But we've also tried to understand the social determinants that affect each of our counties. As Ruben talked about, the Robert Wood Johnson Foundation has a very nice compendium of measures from different sources, which we normally review at least on an annual basis, and we turn that information out to our local health improvement networks. We've also relied upon and appreciate the analysis that Patrick has done and presented at our Leadership Council on the community trends measures. So all these sources and metrics have given us a good understanding of the challenges, the challenges facing this region. We've also gained substantial insight into what makes up effective community-based care coordination. Our implementation of a community HIE in Ellensburg has given us knowledge in that doing care coordination is challenging work and requires the community to see the benefits of this work and push it forward as a group with a shared understanding about where to focus. We've also participated in a statewide discussion with other ACHs that has further refined the definition of the requirements for effective care coordination. There's also been a regional group of ACHs that is coming together to discuss particular practical aspects around care coordination. And our work with the ORNs, particularly Diane's leadership, has given us additional insights into what makes up effective community-based care coordination. As we've talked about, the GCCM model is one of is our foundational work. It's a robust model that leans into the concept of whole person care, which includes work around screening patients for social determinants. Once that data is collected, we work with practices to create internal work processes to manage this important data. We then work with the practices to create referral linkages to outside medical, behavioral, and social service providers. All of this helps to meet whole person care needs. I'll turn it back over to Ruben. Next slide.
Next slide, please, Chelsea. As I mentioned earlier, we have several examples of how successful we have been with this funding, and we have seen how COVID has exposed a lot of the social determinants needs out there. So just really quick, several out of the 30 plus organizations that are doing the work right now, we have here in just one here in Ben Franklin Communities in School. They're doing some wonderful work out there with the students suffering of social determinants. They applied together with DSHS and Safe Harbor to provide them with housing vouchers in Columbia County. They purchased a transportation van equipped with a gurney and other equipment to transport patients to their appointments. In Yakima, Habitat for Humanity received some funding to help new homeowners with their down payment. Also, Yakima Neighborhood Health received some funding to house individuals with significant behavioral needs. So an opportunity is for GCACHs, ACHs and GCACH in particular to push for resources tied to social determinants statewide. ACHs can be that leader, that convener, coordinator that can bring the addressing of social determinants that can, ACHs in general, but I think we are leaders in this category. We can help coordinate that process of financing the work around social determinants of health, and also we can engage others that are pursuing health equity, such as more and more organizations are doing that, government, providers, CBOs, other philanthropies, and even private businesses are really looking into this category and try to be partners. And also just the volunteer and requests that we get from the Benton Franklin Health District, like I mentioned, with the masking campaign, the collaboration with the Transit Authority here, and Second Harvest. So there are many opportunities, and I think we can be leaders in addressing social determinants of health, not just in this region, but in the state. Next slide.
So as I mentioned, we've created, excuse me, we have created a requirement for our practice transformation providers to include screening for the social determinants. This is an important part of their work in year 2. However, this requirement really needs to be extended across all provider types. While it would be great to have a single standardized tool like the Prepare tool that is widely adopted, this is probably not feasible. Many of the EHRs that are being used have their own unique requirements and embedded screening tools. However, the overall need to include social determinant screening remains a very important part of all providers' work that needs to be extended. As well, our contracted organizations have done great work in organizing with their referral partners. Milestone 6 of the Greater Columbia Cares model asks providers to create care compacts or agreements with their high referral partners. More of this needs to happen, including partnerships between mental health and SUD, partnerships with the schools, with the jails, and other organizations. Having formal agreements with community partners in place really is an essential success and helps ensure these partnerships will continue going on into the future. Excuse me. Finally, if you were to ask me or our providers, they would likely tell you that there's really never enough data. Our provider organizations continue to struggle getting population health data and cost data around their impaneled patients. And this has been expressed to the state through their annual value-based payment survey. We continue to hear this from our community partners. VBP and its associated risk requires timely, accurate, and meaningful data about the patient populations being served. The GCACH also continues to look at ways of assessing our own operational performance through practice transformation, which is one reason why we've developed a dashboard in the CSI reporting portal. But more work needs to be done here with the data that we've already collected and additional data that we're collecting right now. And of course, there's always the need to understand more about the social circumstances such as poverty, income, housing, food insecurity, transportation needs, and more that affects this region. I will stop there and see if there are any questions or comments. Next slide, please.
Some pretty meaty technical stuff, as well as some critical things that I think the ACH has embraced over time, that is the social determinants piece. And just wanted to see what board members think about these efforts by GCACH, and as a preface to whether we should continue those going forward. So why don't we back up to those 2 slides on needs and opportunities and see what responses you all may have. I'm going to assume that silence is actually a thumbs up.
Yeah, this is Brian. Yeah, from my perspective, certainly silence is a thumbs up. You know, we've had the opportunities in the board meetings to hear from some of the success stories that were done. I'm reminded of one of the discussions where we spent some time with a guest talking about the work that's been done in Alaska, I think it was. So you just got to find the things and present them. They're good, and people hear them and understand them. I was thinking about Wes's conversation too. Focus on data is tough. Your conversation about the VBP payments and taking risk and not being able to have timely active data, nobody's going to believe you, as a provider, if you can't validate and be accurate with the material, and people can't measure what they're doing as they're doing it. Nobody can do that. I struggle with that just from an operations of a hospital. If I don't have the stuff that my boss is looking at, then how am I supposed to manage to it? So that's those are critical components, and as you mentioned, it's not so much a GCACH thing as much as it is a state thing. You become an advocate for the people at risk at that point.
Right. Okay. Thank you, Brian.
Yep.
This is Carol. I kind of want to put Luann a little bit on the hot seat here, because Luann, your agency lives and breathes social determinants of health, and I've had the extreme privilege of getting a little bit more into the weeds with your organization during the COVID crisis. And I'm just wondering, where you see GCACH filling a gap in that, since United Way does so much to address, after effects of social determinants, and where you see us being the most helpful in this space.
I think it goes back to the previous slide that connects with this. In so many areas, the social determinants of health have root causes that are long-standing, systemic, and growing with COVID land. And so the area where I think GCACH can play a significant role, because of the regional nature of your reach and relationships, is advocacy. And, to really address some of these big issues that are underlying our challenges in the social determinants of health, we need to have coalitions that have a strong voice in looking at policy at the state level and at the federal level, and then how we react to and implement policy as it is changed or not changed. And so I think that is a sweet spot that is not really well filled currently.
Okay, thank you, Luann. Yeah, we'll actually get to that and maybe come back, and I'll ask you another question related to Carol's in a few minutes. I just wanted to pose to the board, do you all understand the social investment model, what Wes and Ruben are talking about there? Do we need to take a little quick dive into that before we shove on to the next set of presenters? I know Chelsea, we're a little behind, but we do have time.
This is Luann, and I appreciate just a little bit more explanation before we go forward.
Okay, so who among you, Wes, Ruben, or Carol would like to talk about that?
I think that would probably be me, Patrick, since this is something that the ACHs are working on with the Healthcare Authority. And really, it's an opportunity to address social determinants of health in a more meaningful way, and tying it to perhaps funding through the state. So we're currently working on a strategy. I think it was North Carolina who is actually funding the managed care organizations to address care coordination and social determinants of health. And so we're just in the earliest stages of defining what that might look like in concert with the Healthcare Authority. So we don't have a lot of detail about it, except that there's widespread recognition really to be able to address and fund some of our provider needs in addressing health equity, and then in general, how to knit programs together that can take advantage of resources that are out there, but might be siloed resources that the ACHs could more effectively bring together.
Okay. Does that help, Luann?
Yes, thank you.
Okay.
And this is Madeline Carlson, and currently I think, with the COVID crisis and everything, it really has brought forth some opportunities. And I know that in Yakima County, and I believe some work is being done in Benton Franklin counties because of our high incidence. That Department of Health is working with FQHCs and helping to get resources available for individuals that are needing to quarantine. So doing that initial assessment and then really connecting them with those community resources to make sure that they have everything that they need in order to safely quarantine. So I think this is, I'm not sure if ACH right now is involved with any of those discussions, but I think it's a great opportunity to really look at how to be able to do those bi-directional referrals from the healthcare provider to the social service provider.
Thank you, Madeline. That's new to me and perhaps new to many others on the call. So I hope Ruben and Wes, you made a little note there. Maybe circle back and talk to Madeline a bit about that as an opportunity. I think we should probably shove on since we do want to leave time at the end for just a set of general questions. So next is the market analysis that Lauren has done, and she'd like to, it's a fairly detailed document, but she's going to synopsize it here, and I think in 15 minutes. Is that right, Lauren?
Yes, that's correct.
All right, take it away.
Okay, go ahead, Chelsea. So I will start off by defining the healthcare sector. The healthcare industry is an aggregation of sectors within the economic system that provides goods and services to treat people or patients with curative, preventative, rehabilitative, and palliative care. Healthcare is delivered by health professionals in allied health fields, but is also facilitated by social services and other care coordination entities. Our board of directors is a good example of the healthcare industry. You represent 17 of those sectors, and it distinguishes us from other organizations offering similar services. Next slide, please, Chelsea. GCACH focuses on bringing people together who have a passion and a commitment to improving the conditions in which our residents live, improving access to services, and understanding what the data can tell us about our population, all of which is key to our success. While focused on the Medicaid clients, GCACH encompasses an array of health services and knowledge base that can benefit all populations. Next slide, please, Chelsea. So how is GCACH changing the healthcare sector? Through the Greater Columbia Cares model, GCACH partners with providers, for example, healthcare, dental, skilled nursing facilities, to provide hands-on technical assistance to shift practices to focus on the whole person. Whole person care is focused on coordinated care, of which results in better health outcomes. To achieve whole person care, an organization must integrate services, for example, behavioral health into primary care or behavioral health into dental. To assist with implementation, GCACH provides the Greater Columbia Cares Model implementation and reporting toolkit that includes descriptive, not prescriptive, milestones, funding tied to quarterly reporting based off of the toolkit measures, and cutting-edge learning collaboratives featuring nationwide experts. The delivery of healthcare services is the most visible part of any healthcare system, both to users and the general public. For most people, it's a confusing system with silos and dead ends, and it's hard to navigate. GCACH is bringing systems together and exchanging information, creating networks that communicate and work together. Next slide, please, Chelsea. So this slide outlines the top 5 organizations within the Greater Columbia region that offer similar services to Greater Columbia ACH. These organizations include Co-Imagine Health, Health Tech S3, Caravan Health, Health Management Associates, or HMA, and Signal Health. Next slide, please, Chelsea. So every organization needs an anchoring ideology to guide it. They need a North Star, especially in a rapidly changing business environment. That's why we look at the mission statements of organizations offering similar services as GCACH. These next two slides include the mission statements from each of the organizations listed in the previous slides. Just as a reminder, I know Carol covered this previously, but GCACH's mission statement is to advance the health of our population by decreasing health disparities, improving efficiency of healthcare delivery, and empowering individuals and communities through collaboration, innovation, and engagement. As we're looking at these mission statements of the various organizations, we noticed a couple of different comparisons. Co-Imagine Health aims to advance the healthcare system, while GCACH advances the health of our population. Caravan Health, Health Tech S3, and HMA are seeking to improve quality patient care, while GCACH improves the healthcare delivery system. And lastly, while Signal Health focuses on collaboration, engagement, and improving wellness of its population, GCACH seeks to empower individuals and communities and decrease health disparities. Next slide, please, Chelsea. Sorry, next slide again. Thank you. This slide outlines the services offered by those similar organizations. Co-Imagine Health offers the following services: system-wide quality improvement, care management, HIT and analytics, and research and evaluation. Caravan Health offers the following: improvement of financial performance, care management, population health, improving patient care, clinician satisfaction, technology and analytics support. Services Health Tech S3 include interim recruitment, healthcare consulting, care coordination, clinical quality and performance improvement, practice assessment, revenue cycling optimization. HMA offers the following services: analytics, behavioral health, for example, integration, clinical services, community strategies, healthcare delivery, development and redesign, healthcare IT advisory services, and managed care. Signal Health offers analyzing system resources and gaps, developing a shared referral system, developing a health information exchange, providing behavioral health care and primary care, providing primary care and behavioral health settings. And then lastly, Greater Columbia ACH, the services we offer include technical assistance for practice transformation, risk management, and behavioral health integration, regional and community coordination, information exchange for data, social determinants of health, health metrics and measures, and Medicaid transformation providers. As you can see, several of these organizations offer care management, quality improvement, data and analytics, advisory services, and services to improving patient care. Some of the outlining services include HMA offering services for interim recruitment and managed care, and GCACH offering information exchange for social determinants of health, that technical assistance, and regional and community coordination. Next slide, please, Chelsea. Thank you. So I outlined some of the key takeaways from the marketing analysis. Number one, the fact that it was difficult to find organizations outside of other ACHs that are similar to us or offer the same exact services as we do. Our board of directors, partners, and stakeholders represent the sectors comprising the healthcare industry, which give us more insight when problem solving, different points of view to understand issues, and deep experience to draw from. The majority of the service lines are grounded in quality improvement, whether it be through software consulting, but no one's offering the one-on-one technical assistance the way our practice transformation team does. This has been confirmed over and over by providers, stakeholders, and even outside experts who have reviewed our work. While many organizations are trying to improve patient care, GCACH is building communities of care. GCACH is supporting the work of our local health improvement networks, educating our communities and decision makers, and addressing gaps in care. Commonalities within the organizations outlined in the previous slide include having professionalism in branding, communications, and events. For example, consistent branding across all documents, newsletters, and events held by the organization. A lot of these organizations have extremely skilled staff. For example, Health Tech S3 and Co-Imagine Health employ RNs, Caravan Health employ a DO. And then several organizations have also received accreditations. For example, CoMagine Health has received accreditation for health utilization management and case management. I also found that the websites for these organizations are very easy to navigate. For instance, it was very clear to learn what they do. In other words, you know, I didn't really have to dig much. Are there any thoughts so far from the board before I move on? I have one more slide and then I'll allow for more question and comments. Chelsea, go ahead. Thank you. So for my research, I believe our primary service line would be to provide consultant services for quality improvement within the healthcare system. Other service lines could include offering learning opportunities featuring thought leaders and subject matter experts, convening, collaborating, and offering insights and bringing about system change, providing transparency around health disparities and gaps, and educating and helping problem solve complex issues. Next slide, please, Chelsea. Any questions or comments?
This is Sandra. Can you just provide a little more background on how we got to the point where we're comparing, how ACOs were selected as a comparison for what the ACH does?
Yeah, Wes or Carol, do you want to talk a little bit how we've talked about ACOs in that model?
Sure, I'll give it a stab, and then Wes, I'd really like your point of view too. But I think, Sandra, the short answer is that in essence, as we are collecting 83 provider organizations and finding commonalities of opportunities for savings, it seemed to us that this could be a possibility for Greater Columbia, and that collectively, if we are bringing down the cost of healthcare within the system, there might be some shared savings that we could all benefit from.
So for those who are not familiar, for those who are not familiar with accountable care organizations, they come together to, it was an initiative through the federal government, and I think it came out of the Affordable Care Act. And Sandra, you probably know more about the background, but in any case, organizations come together, typically health systems, to manage the health of a population, typically under some sort of budgeted arrangement. To do that, they require a lot of data to understand where their patients are receiving care and how much that care costs. But it also requires provider organizations to sort of retool their systems and processes to become more efficient and to reward quality, outcomes, value. So the Greater Columbia Cares model really supports that last part. Building into the data and analytics part would be an area that there's some potential in, but that would require some work. ACOs also come together from the standpoint of contracting as well.
Okay, and I'll just chime in here, Sandra. So there was a conversation that a few of us had, was it last week, with an expert on ACOs from Pittsburgh, and I'm spacing out on the gentleman's name here, Harold Miller. So there has been some research, and we can talk about that in the next phase where we get down into a little more nitty-gritty about how this might work financially. Other questions of Lauren? It's kind of a summary statement that Lauren has put together that could be, if you will, the kernel for a business plan that we'll be asking you about. So just wondered whether you had any ideas that you'd like to add, subtract from Lauren's analysis of the competitive landscape in South Central, actually not just Central, but Southern Washington.
I think it's really good. It's Brian.
Okay, thank you, Brian. Anybody else before we move on? Okay, Kelsey, Lauren, do you want to introduce the next speaker?
Sure, I would be happy to. Next, we will have our Director of Finance and Contracts, Becky, that will take us through the funds flow.
Thank you, Lauren. Thanks, Chelsea. Okay, so this slide shows revenue only from MTP. So as you guys know, we do have a grant that we're working on right now, but this is only MTP funding that we're going to talk about today. So this slide shows the revenue that we have already earned in the top section here for SAR 1, 2, 3. And then we've turned in SAR 4 and we're still awaiting payment on that. So the highlighted cells there are projections for what we think we're going to earn for SAR 4. And then under that blue line are the projected revenues that we are hoping to receive for the remaining SARs 5, 6, 7, and 8. And again, they're highlighted also because they're projections. And we normally, you guys have seen our funds flows when we project our revenues from the SARs. We haven't projected them at 100% of earning, but we did this time. We just because we have received 100% on the previous ones, and we're being a little aggressive in assuming that we will receive 100% on the following SARs, but we're pretty confident. So you can see that the total earnings for the entire MTP project for the 5 years is 86 million. And so we'll take that onto the next slide. I'll show you how we take that into how our expenses match up with our revenue. Thanks, Chelsea. So on this one, we show you'll recognize the first column, our projects and activities. Those all come from straight out of our budgets that you guys approve every year. And some of them are tied to our contracts for practice transformation, but some of them you'll also see like workforce, tribal investment, community health fund. Those are outside of our practice transformation work, which we talked about today. So in this model, Carol and I worked really closely with Dan Gazzini to model out these expenses for us, and Carol and I also had a lot of hours of blood, sweat, and tears over this too, figuring this out. So, so the DY2 column is DY1 and 2 is the first column, and that shows the revenue that we brought in the red line, the red row, which was almost $50 million, and then the expenses for those first 2 years. And as you can see, we didn't have too many expenses because we were just getting this program started. The 2019, which is DY3, are the actuals that we spent, and that was really our first year up and running with our contracts and a pretty full staff. DY4 for 2020, that's where we are now, and so the numbers in that column are directly from our current budget, which was approved for this year that we're over halfway through now. And for 2021, we took similar numbers projecting out for the contracts and the scale and sustain models that we have in place to finish off the demonstration year 5. And then for 2022 and 2023, we don't really know what those years are going to look like, of course, part of this conversation today. So we just projected out the same funding for our providers and our programs for 2022, and then half of the funding for 2023. So of course, that's going to change as we grow and as we create our business plan and we move forward from today. So at the bottom, you can see that the amount of funding that GCACH will have at the end of 2023 is about 7.7 million, which is exciting because I think that that will really help us with this plan that we're creating and help us be sustainable for the future and become whatever we become, the new GCACH.
All right. I think that's it, right, Becky?
Yep, that's it.
So quick questions either about the revenues or the expenditure sides and the resulting carryovers and surpluses between now and 2023 for Becky. Is it a surprise for those of you on the call, board members, to see that we will have funds to operate beyond the official termination of the transformation project? Or is this something that doesn't surprise you?
Pleasantly surprised.
Pleasantly surprised, right. Okay.
So were we.
I think we've been really smart and conservative about money management that I'm actually not surprised.
Okay. Thank you,
Thank you
Sandra.
for that, Sandra.
Yeah. Okay.
I'm
Okay.
also, Dan, I'm also pleasantly surprised.
Right. So, so this tells me that the organization has legs for a considerable amount of time that could be extended depending on how successful we are in creating a strategic and business plan and then actually implementing it. But this is this would be a precursor or a buffer or a whatever we want to call the period of time before we are taking off the training wheels that we've gotten from federal and state funds. Any other comments to the work that Becky and her team has put together here? All right. Well then, let's move on to the final section. We've got about 40 minutes, which is we're just about right on schedule, about how we might go and proceed as an organization. And I just want to point out that we're going to ask questions in this section about how these really good ideas, I think, that you've heard from so many of the staff members, how might these ideas be funded outside of HCA or HHS or any other agency? How might this work? So let's take it element by element, and we'll go to element 1, the consultancy piece. And you've seen that the opportunities we have here are trying to align the toolkit work. If we can just leave it consultancy, there we go. The toolkit work with some sort of a fee for service. And then what would fees look like if we just wanted to add technical assistance and implementation into the mix? Or if we wanted to create a center of excellence on PCMH, would that be feasible on a membership basis? And then would there be an opportunity to ask for some reimbursement for hosting learning collaboratives on PCMH? So any reaction to these potential matching of service delivery and funding? Do you think any of these or all of these are feasible?
This is Loanne. I still don't have enough concept for demand and competition to be able to say it looks generally reasonable, but it's hard to tell the level of opportunity without a more deep dive, which I would assume staff have already done.
Not quite, but that will be the ultimate question. So what you're saying, Loanne, is that you don't feel comfortable weigh in on this without a little more detailed analysis by staff?
I don't have enough knowledge to be able to give them wise counsel yet.
Okay, and we like wise counsel. Any other reactions to the opportunities here in consultancies? Let's go on to the next slide, Chelsea, because it does give some of staff thoughts about who would potentially pay. First of all, would be providers. Second of all, would be health systems, hospitals/providers or hospitals alone. Secondly, third would be payers, and then possibly associations. Do any of these thoughts about who would be willing to pay strike you as likely? Again, we don't need to. You don't need to speak on the basis of an elaborate marketing plan because we don't have one. But just some general reactions. Do you think that from your varied experiences and varied backgrounds that there might be some opportunity for these particular parts of the healthcare system to actually write checks to the GCACH for services and consultancy?
So this is Brian. I think, clinics and health systems are always, that's really kind of where the rubber hits the road. But I also think those guys are pretty tight with their money. I think to the extent that an insurer can gain an advantage by having operating and well-positioned providers that reduce their premiums or spend their medical loss ratios and whatnot. I think they may be willing to support sort of a task team that goes out and tunes up their providers in PCMH. And I think that the associations may have an ability to do it if we package it correctly and build consulting products that focus on how to manage population health, or how to get better at reducing risk and gaining revenues through the new payer system. But I think those are the ones that are tricky. I think this is obviously where the rubber hits the road, and it's hard to figure out who's buying what and how are you going to present it.
Right.
But I would think that the bigger players are probably going to be the insurers and the associations making stuff available.
Okay. Well, thank you.
This is Eric. I was just going to comment that, yeah, I'm a little pessimistic from the health system perspective, only because I've had a little bit of experience with this, with actually CFOs at the two main health systems here in the Tri-Cities, and I cannot make rhyme or reason what they choose to spend their money on and what they won't, even given good evidence. And I'll admit my exposure has been somewhat limited and anecdotal, but I'm pessimistic from the perspective of health systems.
Okay, appreciate hearing that perspective, Eric. Chelsea, can we turn on the pictures again, the video, so we can see each other as we have this roundtable discussion for the next half hour? I think that would be a nice touch. And as you're doing that,
on their own at this point. So if everyone wants to share their webcams, I can't force people to share their webcams. So if everyone is able and has that function.
okay, let's sign back in with webcams then. Okay, hello everyone. Good to see you again. Okay, as we're getting people back on with their webcams, any other thoughts on the likelihood of these services being valued enough that certain players in the healthcare system would be willing to pay for them. So let's go back to that prior slide, Chelsea, and just see again what are those services that we're talking about that would take some perhaps earn some fees. Who's this?
This is Sandra. I think it's a little bit of what Luann's saying with there's an element of unknown as to how many people. I certainly think there are, you know, when we're not tied down to our 9-county region and still within our 9-county region, I think there's a lot of opportunities for providers and insurers who would want to sign on in hopes of achieving some cost savings. I also think that this one is also the one that would have the most risk, of course, because and where we would have to be conservative financially because you know, as things change or priorities shift or money becomes tight at an organization for whatever reason, like, you know, say a global pandemic hits, you know, surprise, surprise, that might happen now. It would be the first service that people would likely discontinue beyond whatever contracted period they have with the organization. So I think there's a lot of potential there that we could maybe start putting fillers out for, but I think the full potential of it, we just don't know.
Okay. Thank you, Sandra. Other thoughts on these opportunities and the associated payments that could come with them?
This is Kat, and you know, I do think it is unknown. I think it is an opportunity. You know, I think one of the pieces that we've thought about in certain spaces is that there are expectations within our managed care contracts related to training with providers. And so, you know, I think there's always, and I think that associations, so let me start with managed care organizations. I think it's just that consideration of economies of scale. And so as we're considering ways in which we have to support those trainings, we try to work in tandem with our other managed care partners. And we have to do that across the state. And so I think it's that sort of consideration of would there be an opportunity to sort of meet that need, or are managed care organizations feeling like they want to keep that in-house? So there's got to be kind of that balance and value proposition of that it's more beneficial to really partner and perhaps support the work that the GCACH team might be doing, and that it meets the expectations of the managed care contract. From an association perspective, I think similarly, there are a number of associations that have tried to build out this capacity to make themselves more valuable in a training space. And so I think just wanting to make sure that it's, again, that value proposition of the work, the sort of proven track record that the GCACH has over the past couple of years, the relationships, the local understanding and knowledge and connections are more beneficial than having something at sort of a broader statewide level.
Okay, great. Thank you, Kat. And you'll probably be hearing more from staff, getting some questions specifically addressed to you. What do board members think about the competitive landscape that Lauren depicted? Do you think that is those organizations are formidable, if you will, competitors to some of these opportunities that are in the area of consultancy work? For those of you who know these organizations. Okay. Apparently not.
Well, I can tell you, I know a couple of them. Health Tech is we work with Health Tech on a number of things. It used to be a hospital management company, and Caravan Health is an ACO. Generally, brings ACO services and kind of links hospitals and providers together, and we work with Caravan Health as a hospital as well. Trying to think, those are the 2 or 3 that we've worked with. I've worked with Signal Health before. That seemed more like a sort of less like a consulting organization, more like a network developer for Medicare Advantage plans.
Okay.
So I think they kind of, I mean, I think they have consulting functions in them, but I think some of them focus on broader things. Like you said, Caravan Health, you're not going to have somebody go out and buy some small functional piece from Caravan Health. They're going to become part of the ACO that Caravan Health is building, and then they'll have those functional components with them. Same probably goes with Signal Health. I think Health Tech is probably more of a a la carte kind of setup.
Okay. Very good. Thank you. Thank you, Brian. I realize this is perhaps a question addressed at providers, organizations like Brian's. So, you know, if we should probably just leave, sort of not put you through the gauntlet if you can't answer those questions based on your organization's experience. Okay.
Actually,
Yes.
Patrick, I actually have a question for Brian and perhaps Sandra, and hopefully I don't put you on the hot seat here, but do you feel that the healthcare environment has really reached the tipping point in terms of feeling the heat from value-based payment and switching their business plan towards the objectives and the foreseeable outcomes that are tied to value-based payment? Or do you think that healthcare is still relying predominantly on a fee-for-service model?
From my perspective, we are still reliant on a fee-for-service model. I mean, the medical staffs, and that's just where we're at. I think different parts of the country are in different phases, and I think we've talked about this before. I mean, certain, you know, when you get into, I can't speak about Seattle because I haven't spent any time really working in the Seattle marketplace, but parts of Florida, you've got some value-based private stuff, but it's still very much fee for service, and I think it will stay that way. I'm sure we've talked about this over time. You know, the organizations, healthcare organizations, are going to get pushed and pushed and pushed, but until Medicare and Medicaid stop paying you fee for service, then hospitals and providers are going to continue to do fee for service medicine. It's what they know and it's what they're comfortable with. Everything changes when Medicare changes. That's how it always works.
Right.
So that's where I would say we are at the moment. I think the effort is convincing folks that, you know, that tipping point is imminent, and how do you get ready for it? Because equally, these same providers are not ready for it. No matter how much they say they are, they're not. So I think that's where the opportunity is. And I think that's what we're trying to do with this entire presentation and what is the future of the organization. It's that. No, that's my perspective on it.
Thank you.
I think for FQHCs, it might be a little bit different. I think we're still riding the value-based payment method, but we're paid differently than hospitals and private provider groups are, based on the nature of how we are established. And so I think we're still very much riding that value-based payment wave. And we have a lot of people who are, I mean, our organization's a little bit ahead of the curve when it comes to that, taking on a lot of, you know, our risk, because we have sort of the size and the resources to do that. A lot of companies don't, but I still think it's being heavily pushed upon us. And I think I don't feel like we've hit the tipping point yet. And I don't think that any of the Medicaid, Medicare groups that we are working with are done pushing and testing the model with us.
Okay. Thank you, Sandra. Kat, you'd be the third person to weigh in here on I think, from an organizational perspective on Wes's question. Any thoughts? Kat?
Yeah, sorry. I have 3 screens, and sometimes when I'm operating on one, I can't get over to the mute button on the other. It takes me a little while. You know, I think Sandra's point is really well taken with respect to sort of the way in which systems are being engaged, and also I think it's really important with respect to the marketplace and the payer. So considerations related to sort of how is Medicare engaging, and considerations sort of what is the what's the payer breakdown for a provider, and so what's going to really drive change for that provider, and so who's their dominant payer, and considerations around sort of how that alignment can work. I think to Sandra's point, you know, oftentimes I think there are many, I can speak at least for Community Health Plan of Washington, but know that this to be the case for some of the other Medicaid managed care plans. We consider primary care as really the quarterback. And so considerations around how do you build models that sort of center within that space. And sometimes that can create, I think we're still in a space of trying to facilitate how do you create that ownership around a payment model within the primary care space and facilitate the partnerships that would sort of be underneath that dominant payment methodology, so that you're sort of seeing value-based payment models underneath that dominant model that is really being held by the primary care provider, so that you're facilitating an expectation with a hospital or a behavioral health provider as well. And I think that that is a space that we still haven't completely sort of broken into yet, or been able to sort of in a comprehensive way sort of crack that nut. I think there are good examples in certain places where there is that sort of partnership approach, but it is not necessarily across the board. I don't know if that answers your question.
And that helps. That helps. So that's a good perspective. FQHC, critical access hospital, and a payer. I think that's staff. You see here a bit of the diversity of experience, which leads to then perhaps a different assessment of need depending on who we're talking about.
I think the one other thing I'll just say is I think it's going to be really important that as we're considering what this transition is, we have been in a space recently where we've been able to incentivize providers to engage in this type of transformation through the funding of district. We are now sort of flipping that on its head to say, pay us for that support because there's going to be a benefit to you, again, whether it be through the model in which you're engaged in. So I think it's just going to be really critical that providers give that feedback of sort of that opportunity and willingness. And you know, I will, as the representative of the managed care organization, I think it will be really key that we, as an MCO sector, continue to come to the table and think about sort of that mapping of what does that overlap look like, and how does that transition. I know that's sort of ultimately been the goal, but I think it's going to be even more important in the next 2 years.
Okay, great, thank you. In the interest of time, we should shove on to the next, your reaction to the next element. You heard about this from Diane and Chelsea. So your reactions to the following bullets here: would there be an opportunity to earn fees from hosting learning collaboratives, hosting meetings, hosting summits? And similarly, would there be some sort of a financial compensation for doing education in the areas of the social determinants of health? Any quick thoughts on that? Is this can some of these current activities actually be funded going forward? And you may not have thoughts on this, but if so, not a problem. But just
so this is Diane. I just wanted to make a comment. So like our opioid summit, we had 4 different tracks. We had hired many people to speak. We actually did a grant through the state healthcare authority that was worth $50,000 on that. But and then there was a small fee that was charged to the attendees. I've gone to quite a few different conferences, different summits for learning opportunities that provided, you know, the education that I needed around my job. And I know that we've paid up to $500 for an entrance fee to be able to attend these meetings, whereas most of ours, we have, if they've been free to the providers, no cost to the providers, I should say. But I think this is one that we could expand on and maybe charge, you know, some sort of fee to attend these learning collaboratives or these learning opportunities or summits.
Okay.
This is Sandra. I will say what's been nice about the learning collaboratives and is that GCACH has, one, they've kept them brief, which I think is very important because no one wants to have providers or staff out of office for these longer conferences, which can often be a challenge. I think they've brought in a good diversity of speakers. And I think, just speaking on behalf of Eastern Washington, it's been nice that they've been local, and I do think that there is opportunity there. And because just based on those three categories.
Okay. So Sandra, just to summarize what you're saying, you think some fee revenue could actually come out of these activities?
Absolutely. You know, especially if we're able to find ways to offer CME, you know, these half-day or one-day opportunities that are more local to our region, easier to get to, not the large multi-day time commitment. I definitely think there is, and again, just based on the diversity and variety and the quality of speakers we've had, I definitely think that's something that people would actually invest in and pay for it. That's reasonable.
Okay.
This is Dan, and I agree with Sandra, and particularly in the area of kind of pulling all the various spokes of the wheel together, and kind of recognizing, looking at it from a total care system. You know, when you're really paying attention to social determinants of health and all the various pieces of that. There's so many other initiatives that are kind of siloed, and because of the diversity of the board and what it represents in the Leadership Council, the Greater Columbia ACH is really able to pay attention to kind of everything that's important and bring that to bear in these meetings. And I would also suggest that there's probably more opportunity to partner with other organizations to leverage kind of our collective with their work, whether it's workforce or addressing health disparities, or like Diane represented the opioid summit. So there's lots of opportunities to insert or intentionally engage other groups.
Okay, thank you, Dan. Any other thoughts on this? Why don't you go to the next slide, Chelsea, just to see what the ideas of the staff was about who could pay for some of this activity. You can see it's quite a list. Some at the local level, and then some at the state level, and then we have, of course, the payer organizations, whether they're MCOs or commercial. Any quick reaction to this potential list of beneficiaries, and therefore people who would, organizations that would help underwrite these activities at the ACH?
This is Ruben. I would add private corporations. I would add the private sector, because especially lately, there's a lot of attention to racial injustice, and private corporations also having a statement, making a statement about racial injustices and things like that. So I can see, especially big corporations, having us come in and make presentations. And so yeah, it's a good business.
Okay, we do have listed there, Ruben, we do have the business community. We could make that more clear. Just
Sorry, I
individual businesses. Yeah. Okay. Any other thoughts before we move on? We're about 10 minutes out to this element of the ACH's activities in the future.
I wanted to just chime in that I think the idea of a membership-based model is something that I think should be considered, because as we look at the idea of a collective impact model and the connector component, the idea of there's a shared responsibility and a shared sort of contribution, and that membership model sort of starts to tie people into that space of that shared ownership.
Okay. Yeah, we haven't talked about the membership model. I'll just say from my perch in Spokane, we have done this on a very small scale with something called Priority Spokane that has kept the organization going for several years. It's a modest membership annual fee, but it certainly allows us to pay for staff.
I personally love the membership models. If we can create something, that's a really good way to do it, because it creates that
okay, that's
foundational kind of basis.
That's something we can explore then, because they're in contrast to this organization in Spokane, I view a membership model here for the ACH as involving dozens of players, right? Okay, let's go on to element 3, if we can, Chelsea. And this is the health equity and social determinants of health piece, and looking at opportunities. You can see that they range from training and implementation, data piece, doing some reporting for providers, fees for hosting and learning collaboratives. That's somewhat redundant to what you've seen there before, but this would be specific to SDOH. You've heard a bit about the social investment funding model, which is very nascent, embryonic at the state level. There's obviously grants and philanthropy, and then we just touched on membership fees. So would people be willing, and I think we've heard some from Sandra just recently, and I think the answer is affirmative. I'll just pose the question again. Is there a willingness to pay on the part of players in the nine counties for these activities? What do you think?
This is Ron Anderson. From my perspective, I would be okay with the county paying some kind of membership fee. But as with everything else that we pay fees for to be a part of an organization or a membership fee, I think it needs to be very, very clear to anybody and everybody that you're asking to pay a fee to or get a fee from. It needs to be very clear that they're going to get a return on their investment.
Right. Yep. I hear you. Okay, so membership fees as a possibility, and what about the more discrete elements of these, where we'd have just episodes or just discrete service payments, much like we see for the fee-for-service model in healthcare in general? Any thoughts on that? Any more thoughts on that? Is the silence indication that you just don't know, or that you are skeptical?
To me, it's more of an I don't know kind of thing.
Okay, that's what I was thinking, Brian.
So there's so many dependencies on these, what the total goal is and all that kind of stuff, that makes it hard to. I think that there are opportunities for some of these things to work with schools. I don't I think that it's easier if you can get some foundation grant funding to get to partner. So to work with the schools, you get some foundation or grant money and a school to partner together, and then that kind of stuff can work. After you've done that for a while, I think that and value is seen, there may be some more direct abilities, but initially I think it would need to be need to find some kind of a grant or something. And membership fees are, I think, are an interesting concept. I think that we would have to be able to show that there's a good reason to be a part of the organization and that the organization has some benefit to the school systems. And I think if we do the social justice and all that kind of stuff, I think there's a really great opportunity there. There's a lot of healthcare organizations that are trying to break into schools right now. That sounds kind of negative, doesn't it? That are trying to offer some services in schools because they see it as somewhat of a market. And I would rather have an organization like ours work with our local health organizations to figure out how to make that happen within our the current providers, instead of trying to add a new outside entity to the mix. I think we need to make better partnerships with our providers in schools to make things work instead of keep adding new players. And that I think is something we could do with the ACH. But again, who's going to fund it? That would have to be from another source, probably.
Okay.
I don't think schools are going to go out looking for it.
Sure. Thank you, Les.
There's a company that actually is coming into Yakima area that it's for free if you get in on the first year, and all these wonderful things about what we're going to be able to do for you, which I'm not sure they're going to be able to do it. How many people are so happy they did it across the nation? All this kind of stuff. Yet nobody's telling the schools that they're start charging a per student fee every year after that. And then when you start adding those things up, maybe it's better to hire a nurse or do something different.
Okay.
I just think that it sounds like a great marketing thing, but it's not really going to service the children in the community like we would like our community providers to do.
Okay. Well, I'll just speak, I think, for the staff, and maybe you don't stop my fingers, but I don't think anybody on staff will do a bait and switch sort of a business model with school districts.
Yeah, no.
So, okay, last minute thoughts on element 3 about how this may work. You want to go to the next slide briefly, Chelsea? We can show the group what the thoughts were. Similar sort of list as you saw from element number 2. So state players, local players, in this case, perhaps the tribes. All right. So then we have about 5 minutes, and I'd just like to pose the question to board members. I don't know whether we still have a quorum. I don't know to what degree we actually need a quorum to make this next decision. So can we go into the next slide, Chelsea? It's under the next steps, and really the final steps for this particular meeting is we wanted to learn from you, the board, whether we, the staff, have a green light to go ahead and develop a business and financial plan around these elements for these quote out years. It could be 2022, it could be 2023 and beyond, given what you just saw in the flow of funds model from Becky. But for a future, should we say, in which there is not substantial support from a transformation project. So the question to you is, can the staff proceed with developing this kind of a model and bring it to your deliberation sometime in early 2021? So thoughts from the board?
This is Loanne. And I just have to say that I've been involved with business startup globally for 2 decades plus. And this is one that I'm very excited about because you're coming into this equation with substantial resources, as in, you know, an amazing startup cachet of funds, as well as the assets that you've been able to develop through this process. So that is a significant leg up. The challenge always is with markets, they're so fickle because just because they could doesn't mean they will. And so I am fully in support of the staff moving forward with a business and financial plan because the devil's in the details. And particularly when we're all, when the markets are all in flux because of COVID and we're reshaping what is the next future. We know we'll go into this with some fluidity, but getting the process started, I'm thumbs up.
Okay. Yeah. Where are those thumbs up that I'm used to in Zoom? Okay.
I would agree with that. Thank you, Luann. That's good.
Thank you.
Okay. Sandra, I agree.
What'd you say, Sandra? I couldn't catch that.
I said I also agree with Luann's statement. I think it's crucial for staff to start this project process now.
Okay. Okay. Very good.
And
Other members?
And can we have updates about how that plan is being developed, or, you know, kind of steps?
So are you wanting a motion for that?
Well, you know, I think that'll be up to Chair Brian or Carol. Do you want a motion?
It'd be nice to have some official action in the minutes that, you know, in concept that the board is approving the ability to develop a business and financial plan. And to answer Dan's questions, of course, we will be updating and bringing you all of the information to help us along. So.
Okay, so Madeline, there's your answer. Would you like to propose something?
So I would move that we approve GCACH staff to develop a business and financial plan for 2021 or further out.
Okay.
This is Loanne. I second the motion.
Okay, good. So it's
over to you.
So it's been moved and seconded to go ahead and begin to build out a 2021 business plan and financial plan. So all those in favor, please signify by saying aye.
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 Thank you. Any opposed? Motion carries. Thank you very much.
Okay, thank you, Brian. So I just, as the facilitator, I want to thank all of you for taking 3 hours out of your day to help the GCACH staff work through this. And I hope it was productive for you. I know it's been productive for staff. They've been preparing for this and really wanted to get your feedback. We are at the hour, but before we sign off, Carol, would you like to say anything in closing?
I think it's been really helpful looking at all the elements that have to go into a business. It's really for staff to determine what are we trying to solve, what problems are we trying to solve. So just thank you to everybody for your time this morning. It's been very helpful.
Okay, and there will be a meeting in September, correct? And do you think staff will be able to get started on this and have to answer Dan's question, have at least a sketch to present to the board at the September meeting?
Maybe a sketch in October. we're right now we're pretty busy doing some mass distribution, but we'll definitely have a good start with the framework that Chelsea has created for it.
Okay.
Sure, that'll be fine.
Chair Brian, do you have any closing thoughts for the good of the order?
My thoughts are, I know you guys put a lot of work into this. We've had a couple of opportunities to talk about it ahead of time. I think it was very, very well done. Kind of gets our heads back into it again, looking forward rather than looking at where we're at every day. So I appreciate all of the work that it took to put this document together. And again, I equally am grateful for all the members taking the time this morning to sit down. It's hard to do that right now. So thank you very much.
Okay. Well, I'll just say I'm signing off from cool, cloudy Spokane. I hope that things have cooled down a little bit in Yakima and the southern Tri-Cities and southern Washington.
Supposed to be.
Enjoy your coming weekend.
Great.
Thank you.
Okay.
Bye now.
Thank you, everybody.
Thanks.
Thank you, everyone.
Thank you.
Bye.